Thank you, Professor Shahab and Professor Shifo, for the nice talk on Minoka. Thanks to the organizers for giving me this opportunity to present on another important aspect of coronary artery disease in females, which is spontaneous coronary artery dissection. No disclosures relevant to the talk. So we'll be discussing the case first, which is a very important and interesting case, followed by different aspects of the SCADs. So this is a 42-year-old female who came to the emergency department with squeezing type of chest pain lasting for 1 hour of duration. She had a prior history of hypertension for last 8 years, and she was on treatment for the same. She had a history of chronic headaches, neck pain, emotional stress, and history of irritable bowel syndrome in the past. Prior to her presentation, she had an exercise stress test that was negative for any evidence of ischemia at 10 meds and 6 months prior. So for the past 2 weeks, she was receiving treatment for her in vitro fertilization. She has one daughter, which is of 8 years of age, and she was trying to conceive through IVF. So at presentation with chest pain, she had positive troponins 18 and followed by 32. And as you can see, her ECG is essentially normal. Subsequent echocardiogram showed normal ejection fraction at 60%. She underwent a coronary angiogram in view of her symptoms and positive troponin. And as you can see, she has spontaneous coronary artery dissection type 2A affecting the obtuse marginal branch. Her LAD was non-significant, and the right coronary artery was also the same. So given her presentation and SCAD affecting the OM branch, she was medically treated, and during the in-hospital stay, her workup was initiated for fibromuscular dysplasia. And while she was having her workup, 3 days down the lane during the hospital stay, she had another episode of severe chest pain, similar to her prior presentation, but increasing in intensity. We did a quick bedside ECG, and that clearly shows that she had some ST elevations in her lateral leads, as you can see in 1 in AVL, and reciprocal ST depressions, and ST depression in V1 and V2. And you can see clearly there is a change from her baseline ECG. Her troponin was about 3. Echocardiogram was performed immediately while she was awaiting to transfer to the cath lab. That clearly showed new wall motion abnormality, more specifically in the LAD territory, with an ejection fraction of about 30%. So the repeat coronary angiogram shows there was diffuse spasm in the distal part of the right coronary artery. But if you look at the obtuse marginal branch, this SCAD had worsened to type 1. We're going to discuss the classification in the coming time. The LAD also had a long dissecting segment from proximal to distal portion. So while taking the radial access, she had ventricular fibrillation, and she required electrical cardioversion. She had a cardiac arrest subsequently with 2 minutes of CPR, and then she revived afterwards. So as you can see, this is extensive multivessel dissection, the intramural hematoma that is causing the compression and severe spasm of the distal RCA. So an urgent heart team meeting was initiated in the cath lab with a discussion with the cardiothoracic surgeon, interventional cardiologist, and admitting physician. And as you can see, if you go back one frame, the distal flow to the arteries is quite patent. The luminal flow is intact, and given these symptoms plus the extensive level of dissection, it was decided that PCI and CABG would be deferred for her, and she was mechanically intubated, deep sedation was performed, and medical therapy was pursued. So she stayed in the ICU for about 5 days, was extubated successfully with no recurrence of chest pain or SCAD, no ECG changes, while her part of her workup was to see for fibromuscular dysplasia, and a CT angiogram showed she had evidence of mild fibromuscular dysplasia as evidenced by beaded appearance of the left renal artery. Also, she had fibromuscular dysplasia affecting the left carotid artery. Prior to her discharge, a repeat echocardiogram was performed, and that showed complete improvement in the ejection fraction to 60%. She was discharged to home, and then at 6 months follow-up visit, we repeated an angiogram that showed complete healing of the dissected vessels. So if you remember, the OM vessel, which was thin and had multiple lumen, now has complete recovery, and so is the LAD disease. And that's the comparison that is shown. Her genetic workup was sent for 2 genes, specifically TSR1 and factor 1 that was negative for SCAD. And she was enrolled in our prospective SCAD registry, which follows the protocol where the patient has to fill the form from Vancouver SCAD registry group. And she mentioned that she had severe stress prior to her SCAD event, which was about a month earlier prior to her event. And the stress was predominantly related to her IVF therapy and hormonal therapies, basically. So SCAD is defined as a non-atherosclerotic cause of acute coronary syndrome that usually occurs in female of childbearing age. It's the cause of STEMI in 1 in 5 females under 50 years of age. And there are 2 mechanisms that are proposed for SCAD. The one is there is an intimal tear. There is a tear that happens in the tunica intima that results in the formation of intramural hematoma that compresses the true lumen and expands the false lumen. While the other theory states that there is directly an intramural hematoma that develops and that compresses the true lumen. Coronary angiogram is the standard of diagnosis for SCAD. Left anterior descending is the most commonly affected artery in about more or less half of the cases. For SCAD, mid to distal portion of the arteries are predominantly affected, while multivessel SCAD occurs in about 10 to 20% of the cases. Accurate diagnosis is essential because PCI in such scenarios is associated with high technical failure and risk of complications, while conservative treatment, as in our case, was associated with complete healing in most cases. I'm just going to show you the first reported case of SCAD. This was in 1931 by Harold Pretty, a young female, 42 years old, who presented with chest pain at around 8 a.m. in the morning. She had a good meal of fried fish and chip potatoes, and the treatment at that time for gastroesophageal reflux disease was castor oil in a mixture of bismuth and soda. That temporarily helped her, but unfortunately the doctor received a call at around 3 a.m. in the morning that the patient had suddenly passed away. The postmortem was performed, and that showed a large dissecting aneurysm involving the right coronary artery. So this was published in the British Medical Journal. So there are potential factors that affect the SCAD. These include the fibromuscular dysplasia being the most common and seen in about 40 to 50% of the cases. SCAD is associated with pregnancy and with multiparity, predominantly more than 4 births, exogenous hormones, and then systemic inflammatory disease. There are precipitating factors that can increase the risk of SCAD. In females, it's mostly the intense emotional stress, where in males, when it's reported, it's mostly related to intense exercise. Chest pain is the most common symptom, and ST elevation MI or STEMI is the most common EKG manifestation. In about 5%, 2 to 5% of the cases, the patient may present with cardiogenic shock. So moving to the classification of SCAD, which is the YPEN-SAW classification, type 1 SCAD basically involves there is the radiolucent, the double lumen pattern that you can see from LAD, as in this case. So when you do an angiogram and you see such a stain, basically you have to do intracoronary nitrates. And if this persists, then basically you're dealing with SCAD type 1. So there is radiolucent lumens or arterial wall contrast staining in type 1 SCAD. Same is the same, and on the optical OCT you can see a hematoma, intramural hematoma that can form, that compresses the true lumen, and false lumen is basically that you can see after that. For type 2 SCADs, it's usually diffuse stenosis affecting about more than 20% of the lumen. It's of 2 types. Type A is basically covered by normal proximal and distal segments, whereas in type B, usually it's the distal segment of the arteries that are commonly involved. In type 3 SCAD, this is the one which mostly mimics atherosclerosis. So as you can see, this area of narrowing, and it's usually less than 20 millimeter in the length. For this type of SCAD, usually intracoronary imaging in the form of IVUS or OCT is recommended that can differentiate SCAD versus atherosclerosis, and the presence of intramural hematoma would suggest SCAD rather than acute coronary syndrome. There are other possible angiographic findings such as increased coronary tortuosity. SCAD mostly involves mid to distal segments, but it can also involve the proximal segments, LAD being most commonly affected, and concomitant association with fibromuscular dysplasia. So the question is when to do intracoronary imaging. It's again, you have to balance what is the risk versus the benefit, like in type 3 SCAD where the diagnosis is uncertain or the lesion is unclear, and you have to look at the proximal segments mostly. As for the distal segments, mostly it's the medical therapy that is pursued. IVUS can greatly assist in the delineation of true and the false lumens, and the typical appearance is the black and white appearance that you commonly see, delineating the intramural hematoma from the lumen wall itself. OCT also has a much higher resolution compared to IVUS, and it can also differentiate between true and false lumen. In the comparative studies in SCAD with IVUS and OCT, both have been similar, but OCT was slightly more superior and better sensitive in detecting the characteristics of SCAD compared to IVUS. CT imaging can be utilized if native coronaries are concerned. Like in this case, this was a case series published in the ESC journal where CT scan showed SCAD, type 2 SCAD involving the LAD territory, and this was confirmed with the coronary angiogram. Subsequent follow-up with it also confirmed healing that was seen in both CT scan as well as coronary angiogram. Predominantly, the role of CT scan is to identify the extracoronary anomalies such as the presence of dissection, fibromuscular dysplasias, and aneurysm involving the vertebral artery in this case. Also, it can identify tortuosity. Tortuosity is also linked with increased risk of recurrent SCAD. CTA specifically can greatly help in identification of fibromuscular dysplasia, as in this case, you can see strings of bead appearance or pearl appearance in the renal artery, aneurysmal formation, and similarly in the femoral artery, you can see the interrupted appearance or the strings of bead appearance. Now, the management involves, if it's clinically stable, it's a conservative treatment strategy. Those with severe left main or proximal or two-vessel dissection, I believe conservative treatment still should be the first line of goal, but in case if the symptoms are kind of getting worse or there is hemodynamic instability and there is poor flows, then cabbage versus PCI can be considered. So observational data indicate that healing occurs in most of the SCAD lesions in about 70 to 90% of the cases, and most of the healing usually occurs by first month after the presentation. The early complications are usually recurrent myocardial infarction that occurs in about 5 to 10% of the cases, and usually it's the extent of the dissection that occurs in the first 7 days. That's why extended period of inpatient monitoring is justifiable in these patients. Exceptions include ongoing ischemia, left main involvement, and hemodynamic or electrical instability. Antiplatelet therapy, aspirin is usually indicated. The role of clopidogrel is usually unclear, mostly indicated when there is percutaneous coronary intervention is performed or a bypass surgery, but at least 1 year of aspirin is usually indicated in these scenarios. Beta blockers and ACE inhibitor therapy for SCAD, data from the Vancouver SCAD registry showed that the utility of beta blocker prevented the recurrence of SCAD with compared to those patients who were not on beta blockers. It is usually indicated for those SCAD with LV dysfunction, those with arrhythmias, and for the management of hypertension. Statins generally are not recommended given the fact, especially in pregnancy, but their role is only if there is any primary atherosclerotic disease or established diabetes mellitus. Now, as I mentioned, that the PCI is mostly associated with high technical failure, and as you can see, the reason mostly is that the wire can enter into the false lumen. It can cause or increase the risk of iatrogenic dissection. If the intramural hematoma expands, it can cause under-expansion of the stent, and further propagation of hematoma can occur. However, the Mayo SCAD registry in this group of patients with the 189 patients PCI was performed in about, or revascularization was performed in about 50% of the cases. The conventional, the PCI failure rate was about 50%, and the target vessel revascularization at follow-up was also high, which was about seen in 25% of the cases. Whereas in the conservative arm, 90% of the patient had uneven in-hospital stay, though 10% of the patient did experience SCAD progression and required revascularization. What to do in patients who presents with SCAD and concomitant STEMI. So this is a registry that showed observational data study that showed that females are more commonly affected with SCAD and STEMI. Left main involvement is quite common. They usually present with cardiogenic shock. Revascularization with PCI was done in about 70% of the cases. TIMI-3 flow was achieved in about 90% of the cases, so compared to about 99 or 95% in patients who present with STEMI with atherosclerosis, but yet it is associated with excellent 3-year survival rates of about 97%. So as I mentioned, PCI is associated with some technical failures. We have discussed this. Some other things are the stent malapposition that can occur due to propagation of the intramural hematoma. And that's why in the SCAI guidelines or the AHA guidelines, it is a class 3 recommendation, which is not recommendation in those with routine SCAD. 2B, because we don't have much data, unfortunately, in those who have hemodynamic instability or ongoing ischemia despite the conservative therapy. CABG has been considered for those with, as I mentioned, those with technical failure with PCI, left main stem or proximal dissections, and ischemia persisting despite the conservative therapy. In this case series where CABG was performed in patients with SCAD, interestingly, 24 grafts were placed. 8 out of the 9 were arterial grafts and all failed. 9 out of the 15 venous grafts were patent. So one example was shown 8 days after the surgery, CT scan was performed. You can see that the Lima to LED is patent, but the false lumen is completely thrombosed. 7 months after the surgery, repeat CT scan shows that the flow to the LED is completely restored because the SCAD has healed, but the graft itself became completely atretic. So discussing the outcome, early in hospital outcomes with SCAD are about 10 to 14%, and they may require urgent in-hospital revascularization, usually because of the extension of dissection. Patients should be at least monitored for 48 hours, preferably 3 to 5 days, depending upon the clinical scenarios, and a repeat angiogram may be warranted if they continue to worsen clinically. Physical activity, usually, like in our case, I forgot to mention, the patient prior to discharge was enrolled in the physical therapy unit, and then subsequently she followed up for about 6 months or so, and she did quite well on the physical therapy aspect as well. There's a general protocol available with the Vancouver group where they don't target the blood pressure beyond 130/80, heart rate of about 50 to 70, and free weights for resistance training. They start slow and gradually build up. Psychological considerations are as important as in patients, especially who present with atherosclerotic MI, like acute coronary syndrome, and they are important in SCAD as well. And anxiety and depression is known to cause, commonly occur among patients with survivors of SCAD. In a cross-sectional data, it was reported 40% of the patients had depression and anxiety at some point in their life. Repeat coronary assessment mostly is indicated for those with multi-vessel SCAD, left main involvement. It's done, but there are a few more slides if you can just quickly go through.
30 seconds, please.
Yeah.
You can speak.
Oh, okay. So I'll just skip this. Okay, so the recurrent SCAD is associated with about 10 to 14% of the cases. Coronary tortuosities and hypertension is predominantly associated with recurrent SCAD. SCAD can also occur in males. 10% of the patient in this registry had, male patients had SCAD. They had less history of depression, and the in-hospital mortality was similar in both the group. In the real-world data, in our study, we have about 5 patients with SCAD. All were females. type A SCAD was most commonly seen. So to conclude, I would say SCAD is commonly seen, very commonly seen, a diagnosis of high index of suspicion should be considered in females, specifically less than 50 years of age, multiparous, presenting with chest pain, and where required, coronary angiogram should be performed in such scenarios. Patient should be enrolled in physical therapy unit and closely followed up for subsequent events. Thank you.
Excellent. Thank you very much.